Good morning, good afternoon, and good evening to everyone joining us from around the world. I'm Claudia Vandrasek. I'm the Director of Programs and Integration for the Breakthrough Action Project, and it's my pleasure to welcome you to the first webinar in the Breakthrough Action series, From Insights to Impact, Leveraging SBC for Sustainable Change. Today's session is entitled Innovative SBC Solutions for Health. For health, excuse me. I wonder if we should wait any further to get started. I think we'll go ahead and get started. So, slide. This 5-part series is designed to showcase the transformative power of social and behavior change, or SBC, initiatives worldwide. Through these webinars, Breakthrough Action aims to inspire, inform, and encourage you to adapt these proven approaches in your contexts. Slide. Today, you'll learn about 3 groundbreaking SBC interventions that have been developed in close collaboration with local communities and health practitioners. And I invite our speakers to come on camera so that we can see them as I introduce them. Dr. Bolatito Ayenigba is the Deputy Project Director for Malaria and Tuberculosis at the Johns Hopkins Center for Communication Programs in Nigeria. And Dr. Ibrahim Aliyu Umar is the Director of Public Health and Disease Control, DPH&E, for the Tuberculosis, Leprosy, and Buruli Ulcer Center Program, Kano State in Nigeria. And the two of them will speak about the simplified referral for TB testing, an approach that effectively bridges the gap between demand and service uptake. Then you'll hear from Leah Mallet, Associate at Camber Collective, and Dr. Tessera Bitu, Associate Professor of Mental Health Epidemiology, working as Director of the Research and Publications Directorate of Injibara University, Ethiopia. And together they will speak about Mother's Time, a tool which equips community health workers to support new moms, mental health, fostering reductions in postpartum anxiety, and encouraging FP-related behaviors. Last but not least, you will hear from Colin Elumba, SBC Coordinator in the Kasai Oriental Provincial Office for Save the Children in the Democratic Republic of Congo. He will share the story of the cost comparison activity that is helping community members overcome perceptions of healthcare services as being cost prohibitive. So thank you all to our speakers today, and I would invite you to close your cameras to preserve your bandwidth. So let's go to the next slide. Some logistics. Before we dive into the presentations, just a few housekeeping items. This session will be approximately 60 minutes long, including time for questions and answers at the end. We encourage you to submit your questions through the Q&A feature that hopefully you are seeing at the bottom of your screen. It's a box with a question mark in it. And we'll do our best to address as many of the questions as possible, either in the Q&A feature or live by the presenters. We're also pleased to offer simultaneous interpretation in French for today's webinar. To access the interpretation, please click on the interpretation icon also at the bottom of your screen, and select the language you wish to hear. This will ensure that all participants can fully engage in today's important discussions. I note that the third presenter will present in French. So if you are not a French speaker, please go to that interpretation icon and choose your language. Great, next slide then. So without further ado, we're going to dive into our first presentation from Nigeria, the simplified referral for TB testing. And our speakers, Dr. Ibrahim Aliyu Umar and Bolatito Ayenigba. The floor is yours.
Hi, good morning, good afternoon. My name is Justin D. Normandy. I'm the Social and Behavior Change and Innovations Advisor for Breakthrough Action Nigeria. I'm stepping in for Dr. Bolatito because she's having some connection challenges. Happy to be here. So just to start off, the problem in Nigeria was a huge number of undetected cases of tuberculosis. Globally, Nigeria has one of the lowest rates of tuberculosis case detection in the world, with less than 26% of the estimated cases being notified in 2018. Next slide. What we learned through a human-centered design approach is that people who have TB would go to very different channels to seek healthcare, including religious leaders, friends and family, pharmacies, and local community medicine stores. We learned that people were very reluctant to visit health facilities, the one place where they would get proper care, because of concerns about the cost. Next slide. Ironically, in Nigeria, testing and treatment for tuberculosis are free. In addition to that, there's a toll-free national hotline where people can call and get information about where they can go and get tested, and also receive information, more information about tuberculosis. Next slide. So the solution that we came up with was linking these medicine stores where people are frequently going, people who have tuberculosis would frequently go to visit and buy cough syrup, often returning to the same medicine store to buy cough syrup as soon as they run out. So the idea was we should link people going to these medicine stores to the hotline where they could get information about tuberculosis and where they can go and get free testing. Next slide. Now I will hand over to Dr. Ibrahim Umargano.
Thank you very much. And with this insight and the need for us to work with what is available, the efforts of TV program in Nigeria in collaboration with Breakthrough Action Nigeria was to see what can we do, make over, and to do where, who where, and to do what. Earlier attempts by other projects was to ensure that we work with store shops and other staff that would likely be given incentives to work. But with the aim of the project, with better action, we learned that we can do something different by what? By making a turnover. Makeover was what is in the mind, working together, reaching out to the common PMBs or patent proprietary medicine vendors, and then giving what we call a referral. Next slide, please. Yes. So in doing it better, Breakthrough Action Nigeria, in collaboration with the National TB and Leprosy Control Program, designed a simplified referral scheme, which can be domiciled at the nearest shop, and then can be turned off, and then can be given to a client coming to the facility with symptoms of TB. And then a calculator was used to ensure we keep track and count how many referral slips were given, and ensure an M&E framework for that. Next slide, please. So, and then going ahead in that line and going faster and smarter, we learned that instead of calling for these shops owners or chemist owners or patent proprietary medicine vendors to have a comprehensive training, we can do the same comprehensive training on site, where we orient them on site, give them the guidance on what to do, and then leave the slips and other things for them to make referrals, and then later coming back to see how many referrals were made. And then the on-site screening was very, very nice, and we found that to be very, very interesting. Next slide, please. Now, what have we seen? What was the evidence? In the pilot test, we had a promising result. One, in testing how resilient and effective our system can be. With the support of Breakthrough Action Nigeria, during the co-design approach, we learned that whatever we gave as a form of orientation, and then with the slip left with the store owners, and then coming back later in the day, even with mystery clients that would come to present themselves with symptoms of TB, the yield was nice, was good. Because instead of just issuing out cough syrup and other things, When patients come with symptoms of TB, at least 2 out of 3 patients coming to visit the medicine shops were given referral slips and then put to the nearest facility for TB screening. Next slide. Now, in the scale of this intervention supported by Breakthrough Action Nigeria, we had over 9,000 patent and proprietary medicine vendors, which we call commonly chemists here in Nigeria, in 8 states of intervention from 2020 October to June 2024. And in those institutions or platforms or PMBs who are ordinarily very, very ready and willing to give referrals to the clients, over 40,000 people were screened or tested for TB, following referrals from this very important PPMB considered states in Nigeria. Next slide, please. Now, what have we seen? With the insight and discussions among stakeholders to see what can we do to ensure proper MIE framework and structure, and to ensure good reporting, and we are gender sensitive to ensure capturing of all information. There was an adaptation for the referral slip where age and gender were captured in the updated version of the referral slips. Next slide. And you can see on the referral slip, we also have the toll-free number which clients can call for further information. Now, what was the result? Over 10% of our positive cases were diagnosed and placed on treatment from over 40,000 referrals that were completed in as much as almost 60,000 referrals that were made by PMPs. Very nice result. Next slide, please. What have we learned? We have learned that in this intervention, some people felt entitled to VIP treatment, but still communication was needed to ensure we met the expectation. We also learned that we need to use some other strategies like use of folders and box to ensure some facilities keep their referral slips. So also PMBs were highly motivated and ready to support even beyond the journey we had. And then feedback or referrals was also very nice in ensuring motivation, and the non-monetary incentives like recognition, training, and other things were also very, very important, including media appearances, engagement, and other platforms for recognition, which were very, very encouraging to the PMDs that have worked within the project. Next slide, please. I need to acknowledge very important personalities, especially the National TV, Networks and Bully also Control Program, Federal Ministry of Health Nigeria, the state programs of the 8 intervention states, ASID, KNCV, IHGN, and all the PPMBs that have worked with this project in Nigeria through the support of Breakthrough Action Nigeria.
Excellent. Thank you ever so much, Dr. Aliyu, Dr. Ibrahim Aliyu, and Justin de Normandy as well. Thank you so much for stepping in for Tito, who was having some difficulties joining us. That was a terrific presentation, and it was great to hear how simplifying the referral process for TB testing by using medicine store staff and providing them with easy-to-use referral slips has significantly improved TB detection rates in Nigeria. This approach demonstrates the power of meeting patients in their communities and the importance of designing user-friendly systems that align with the daily operations of the informal private health providers. And I note there was also a benefit in terms of the monitoring of the effects of this intervention. So that is just terrific. I invite anybody that has any questions for Dr. Ibrahim or Justin to please put those in the Q&A, and we will get to those later in today's webinar. So, slide. We'll now move to our next speakers from Ethiopia, Dr. Tessera Bitu and Leah Mallet. Over to you.
Thanks, Claudia. Hi, everyone. As Claudia mentioned, my name is Leah, and during this next 10 minutes, you'll hear from me and my colleague Tessera, who will share the results from a cluster randomized control trial regarding cognitive behavioral therapy tool called Mother's Time, which was tested in Ethiopia among postpartum mothers with mild to moderate anxiety and depression as a tool to address both anxiety and depression and family planning. You'll see that the results show promising evidence for the use of cognitive behavioral therapy tools to improve postpartum mental health and support women in low resource settings to realize their reproductive intentions. And before we jump in, I do want to give a special acknowledgement to Dr. Zoe Hendrickson, who was the PI on this study and for whom this study wouldn't be possible. I also want to acknowledge the others on our larger team among this effort, including Dr. Andanette Halley with Deep Dive Consulting, the team at Johns Hopkins Center for Communications Programs, including Lynn Van Leith, Stella Babaloa, and Dominic Shaduk, and then others on the Canberra team, including Jessica Moore and Sarah Burgess. So the primary problem that we were solving for in this study was the fact that many postpartum women have an unmet need for family planning and experience depression and anxiety. This is an issue globally, and it's also an issue in Ethiopia where this study took place. There are several reasons why these gaps exist. So the image on the right-hand side of this slide is not a comprehensive list, but some key reasons include health systems barriers. So this includes staff shortages, burnout, and time pressures. Another reason is care-seeking barriers. So in a lot of contexts, women who suffer from mental health challenges often face shame, guilt, and reduced quality or access to care. And so part of the goal of this intervention we'll be discussing today was to identify a simple way in which these gaps in access to mental health could be addressed without burdening health workers. So I'll now hand it over to Sarah on the next slide to share details on the intervention and the development process. And to
Hello,
Sarah,
thank you.
you're on mute.
Thank you, Leah. I can hear you now.
Great. I can hear.
The cognitive behavioral therapy, therefore, is supposed to be an intervention for common mental disorders like anxiety and depression that is widely prevalent in the low-income countries, particularly, and globally in general. So the CBT or cognitive behavioral therapy as works on improving thoughts of women from unproductive thoughts to productive thoughts, so as to improve their emotions and behaviors. This CBT was widely used by WHO, and it is entitled as Thinking Healthy Manual. It was promising approach in reducing anxiety and depressive symptoms across several low and middle income countries. Next, please. So the solution is Thinking Healthy was adapted to improve family planning among women with postpartum depression and anxiety in Ethiopia. Breakthrough action with Ethiopian experts developed mother's time intervention for community health workers, the providers or the deliverers of this intervention to use for postpartum women experiencing moderate symptoms of anxiety and depression. Intervention was pilot tested and refined based on feasibility study, and each session took about 60 to 90 minutes, and it was delivered to a small group of women, 4 to 6 women, I mean. And women were given homework, simple homework, so as to exercise the activities. So generally there were 4 sessions, and in each session, there was a target was to change unproductive thoughts and to replace unproductive thoughts with productive thoughts. And homeworks were also targeted to exercise or to replace these productive thoughts. So next, please. Yeah. So that is the result of randomized control trial and the methods. Leah would continue.
Thanks to Sarah. So the purpose of this current study was to assess the effectiveness of this updated Mother's Time intervention on symptoms of depression, anxiety, and associated behavioral and social barriers to postpartum family planning in a larger sample. So the study was implemented in 2023 between May and November, and data was collected at 3 distinct time points: baseline, which was pre-intervention, end line, which was immediately following the intervention, and then 3 months following the intervention. As mentioned, this was a cluster randomized control trial. So clusters in this sense were at the health center level. So clusters were randomly assigned to either the intervention and control arm, pre-intervention. In the intervention arm, the HEWs were trained to deliver the intervention that Sarah just described. And then mothers in the control arm received the standard of care that postpartum mothers in Ethiopia receive. And standard of care in Ethiopia tends to correspond with multiple touch points for postpartum care as well as routine immunization. And then anticipating that the mother's time intervention would be superior to standard of care with respect to reducing symptoms of stress, depression, and anxiety, women in the control group were offered the opportunity to opt into the intervention once data collection was completed. Next slide. So what were the results of this cluster randomized control trial? So, in terms of mental health symptoms, we found that the intervention had a significant effect on reductions in anxiety at both endline and follow-up, and significant reductions in depression from baseline to follow-up. Next slide. With regard to some of the interim indicators, behavioral indicators that are predictors of family planning uptake, we looked at communication with the partner as well as having a final say over pregnancy prevention. And when looking at this, for both of these indicators, we saw that the intervention showed a significant increase in both family planning communication as well as having a final say regarding pregnancy prevention from baseline to end line, though these changes were not sustained at follow-up. This tracks with what we were expecting in terms of the mother's time theory of change, where we expected to see changes in mental health symptoms immediately following the intervention, and that these would that the intervention would also shift some of these more proximal indicators, and that family planning uptake would follow some of these interim indicators. Next slide. And consistent with that theory of change, so with regard to actual using a modern family planning method, we saw that there was a significant increase from baseline to follow-up, but we did not see a change immediately post-intervention. Some hypotheses for this include mothers might need time to speak with their partner, as we saw in the previous slide, or speak with a health worker about initiating a family planning method. And then the last indicator that we looked at was intention to use family planning in the future. This was one of the only indicators where we did not see any significant changes. However, we did see that among those with intentions, women in the intervention group appeared to be more likely to act on those intentions. So that's that bar that's called out right there. Next slide. And I'll hand it over to Sarah to close us out with the potential scale and adaptation for this intervention.
Hello? Can you hear me?
Hear you, Sarah. Yeah.
Great. So the potentials for scale up of the intervention and recommendations and suggestions for future work will be discussed here. So include mental health in community health program and health system strengthening efforts is one of the recommendations, and consider mental health in design of community health work care packages, which is not existing currently. Though the package exists, service is not existing, and So considering mental health in the design of community health workers care package is also important. Leveraging HSS approach to maintain balance in community healthcare workload and address access to capacity gaps in the primary healthcare environments connected to them is also another recommendation. Then exploring the intersections between mental health and sexual and reproductive health behaviors and norms was not done, and this is also another area of recommendation. Particularly understanding intersecting normative and behavioral drivers for family planning and mental health to better tailor future CBT programs, and considering expanding CBT curricula to include the programs in general. Exploring the integration of mental health into family planning and maternal, newborn, and child health programming also remained there as one of the recommendation areas, like identifying avenues for integrating mental health in family planning, counseling, and education, training community healthcare workers to administer patient healthcare questionnaire, which we used for screening purpose, and GAD-7, Generalized Anxiety Disorder 7 scale for screening tools during antenatal care, postnatal, and child health visits to detect and treat mental illnesses. And
So Sarah, would you mind wrapping up? I think we're at time.
yeah, so tailor and scale up CBT in general is the recommendation of this study. Thank you.
Thank you so much. I'm sorry to cut you off, Tessera. Thank you both, Leah and Tessera, for sharing the promising results of the Mother's Time intervention. This intervention demonstrates that community health workers can deliver cognitive behavioral therapy to not only support women's mental health, but also enhance partner communication and family planning decisions. If you have any questions about the presentation, please submit them to the Zoom Q&A that you'll see the button down at the bottom, and we'll address them during the webinar's Q&A session. Slide. So last but not least, we'll hear from Colin Ilumba from the Democratic Republic of Congo. He will present in French, so please take a moment to choose the language you wish to hear his presentation in if you have not already done so. So over to you, Colin.
Bonjour, je suis content de vous présenter l'expérience de la RDC en faveur de l'augmentation de l'utilisation des services de santé grâce à une innovation développée par le projet Breakthrough Action appelé les coûts comparatifs. Next. La RDC est un pays pauvre qui se trouve parmi les 5 pays du monde les plus pauvres. Cette pauvreté diminue l'accès aux soins de santé. Seuls 40% de la population utilise les soins de santé primaires. La population pense que les soins de santé, même primaires, sont trop chers et par conséquent, cherchent à se faire soigner ailleurs, chez les tradis praticiens, ou parfois ils se rendent à l'église lors des cas tels que les cas de fièvre, des accouchements, ou parfois ils font de l'automédication. Next. Dans le processus de la recherche d'une solution, nous avons fait une recherche qualitative en 2019 dans 6 zones de santé pour mieux cerner les vécus des populations et leur perception sur la recherche des soins de santé. Nous avons collecté beaucoup de verbatims, parmi lesquels nous avons entendu des gens dire, par exemple, « Je ne veux pas au centre de santé car je suis sûr que c'est cher. » Next. Vu que la décision de chercher les soins est basée sur les coûts et non la qualité et l'efficacité des soins, nous avons senti que les populations négligent les risques associés à la recherche des soins auprès, par exemple, des tradis praticiens ou à l'église, parce que là-bas, il n'y a pas de personnes formées. Les participants à l'étude nous ont dit, par exemple, qu'ils priorisaient les dépenses pour la nourriture et l'éducation avant de penser aux soins de santé. Nous nous sommes alors demandé comment pourrions-nous changer cette perception sur le coût des soins et amener les gens à comprendre que les soins ne coûtent pas trop cher en réalité. Next. Alors, pour répondre à cette question, nous avions remarqué aussi d'abord dans la population que bien que la population était butée à des contraintes économiques, mais le famille dépensait de l'argent dans des achats de choses communes, d'ailleurs, qui sont secondaires, qui ne sont pas directement liées à la vie, telles que les cheveux, l'alcool, la cigarette, les jeux de hasard, les maquillages. Et si nous avions pensé à amener la population à comparer maintenant le coût des services de santé et les dépenses secondaires. Ces dépenses secondaires, nous avons dit la coiffure des hommes, la cigarette, la loterie, les boissons sucrées, par exemple, les crédits téléphoniques, les maquillages, les mèches. Et nous avons mis maintenant en place ces prototypes interactifs que nous avons appelés les coûts comparatifs pour comparer les coûts réels, par exemple, des services de santé et les prix qu'on dépense pour certains articles, par exemple, secondaires. C'était vraiment comme une révélation pour la plupart des personnes. Les gens hochaient la tête lors de l'activité et s'exclamaient, ah, que vraiment les soins ne coûtent pas beaucoup comme on le pensait. Next. Et l'objectif du coût comparatif que nous avons mis en place était d'amener les communautés à mieux percevoir le coût des services de santé pour ensuite rechercher les soins en cas de fièvre, de la toux, la diarrhée ou les CPN ou les accouchements. Grâce à cette découverte, qui est le coût comparatif, on a enlevé un obstacle à la fréquentation des services de santé. Il y avait une très forte participation par les communautés qui généralement donnaient les exemples des articles pour comparer les coûts réels des soins. Next. Vu que l'activité était beaucoup appréciée et avait une très forte participation, nous l'avions intégrée dans presque toutes les activités communautaires, qui sont le fait de couple, les quiz au marché, les visites à domicile et également les séances de CPN, de CEPON. Next. Les populations disaient que les soins ne coûtaient pas cher, mais qu'elles ne pouvaient pas avoir de l'argent à tout moment. C'est alors que nous avions pensé maintenant de coupler cette intervention, le coût comparatif, avec une autre intervention qui est la caisse d'épargne. Maintenant, pour aider les gens à comprendre qu'elles avaient la possibilité de mettre de côté quelque chose qui pouvait servir les moments de maladie. Cela a été encore très intéressant. Vous voyez par exemple quelques participants qui ont même dit, il y a un qui dit sur base de ce que nous gagnons de nos activités d'agriculture, nous commençons par répartir nos produits, certains pour la consommation et d'autres pour la réserve et s'acquitter des dettes antérieures du centre de santé. En cas de maladie, nous faisons recours à notre caisse familiale pour le paiement des soins de santé. Ça, c'était un participant du Sud Kivu. Next. Alors, vu l'engouement à l'activité des coûts comparatifs, nous l'avions intégré dans toutes les activités communautaires, comme nous l'avons dit. Alors, nous avons mis en place l'étiquette de rappel que vous êtes en train de voir sur les diapositives. Alors, pour mesurer les références vers les services de santé à partir des activités communautaires. Et là, jusqu'à 21% des tickets ont été présentés dans les services lors des CPN, lors des cas de fièvre et lors aussi des cas de toux. Next. Nous avions eu, oui, nous avions eu vraiment plusieurs témoignages grâce à l'association que nous avions entre les coûts comparatifs et la caisse d'épargne. Là-bas, par exemple, des gens qui disaient, quand j'avais 500 francs congolais, par exemple, qui équivaut à 1,76 dollars, j'ai dépensé sans objectif. Mais maintenant, je garde l'argent et mes enfants ne sont plus chassés de l'école. Et même s'ils sont malades, nous partons au centre de santé. Au début, nous avions intégré l'activité uniquement dans 110 heures de santé et 8 zones de santé et 4 provinces. Next. Mais comme l'activité était vraiment aimée et apportait beaucoup de résultats, nous sommes passés à l'échelle de 8 zones de santé à 179 zones et de 4 à 9 provinces, bien sûr grâce au projet IHP ProSani et les organisations locales qui travaillaient en santé. Next. Une évaluation qualitative adaptative de l'approche changement le plus significatif qu'on a menée en 2021 avec 236 interviews qu'on a fait dans 3 zones de santé au Sud Kivu et également 424 entretiens, là c'est dans le Haut-Katanga. nous a permis de trouver les résultats comme ça, qu'il y a eu des changements, par exemple, dans la perception des coûts des services, et également, les couples ont acquis de nouvelles habitudes d'épargner de l'argent en faveur de la santé, en minimisant les autres dépenses non essentielles au foyer. Next. Alors, le coût comparatif a été intégré dans 5 districts sanitaires au Togo, vu vraiment les résultats. Et là, c'est au cours des dialogues communautaires spéciaux hommes. Grâce à cette activité, les hommes se sont rendus compte que la planification familiale était financièrement accessible. Par exemple, le coût pour la méthode injectable équivalait tout simplement à une bouteille de bière. Et l'accouchement simple équivalait juste à une paire de chaussures. Next. Voilà, au nom de toute l'équipe de la RDC et l'équipe d'appui, nous vous disons merci pour votre attention.
Merci beaucoup, Colin. C'était très bien. Thank you, Colin, for sharing these valuable insights. The cost comparison activity shows us that the perceived barriers to healthcare costs can be overcome with simple community-driven solutions that change the view of the affordability of healthcare. As we've seen, many everyday expenses exceed the cost of necessary health services like antenatal care or childbirth. So, now we'd like to open the floor up to any questions or reflections you may have. I note that we already have several questions in the Q&A, and I note too there are several questions in the chat. In order for us to treat your question, please put it in the Q&A portion of the Zoom bar at the bottom. Otherwise, we may miss your question. So we're going to go ahead and open up the floor. Let me get to my questions page. And if the presenters want to come on camera, that would be fine as well. So I think we'll start with questions for Dr. Ibrahim. And basically the question is, during referrals for tuberculosis care, didn't clients ask for transportation costs before coming? Also, how do you go about getting government players more involved? So if you would handle that first question.
Thank you very much. That's the beauty of the strategy we adopted in Kano, in Nigeria. One is to ensure we create demand for what we call risk perception. Clients, when they came, they had symptoms and they are looking for solutions. When we offer that we're doing this ABCD, you'll be able to confirm whether you have TB or not, and you are choosing of neighbors or other colleagues. It's easier for to have TB for you, there'll be treatment for you, and then there'll be preventive measures for you.
Dr. Ibrahim, please speak, hold the mic a little bit further from your mouth.
All right.
Because it's hard to hear you.
Exactly. So it is that strategy of making sure that we engage the clients with this communication and community engagement that has made them to not even think of that. In fact, when we ask them, they will be asking for where is the place to be tested. We will tell them we have nearest place for screening. They will say wherever it is, we will go there because we just want to get tested. And now that it's free of charge, we just want to get to know whether we have TB or not. That is very, very encouraging. So we don't have that influence of that, but at the same time, there are patients who may be difficult that may be needing one or two support to be able to reach out to the nearest place for screening. That's number one. Number two is the strategy of government. That is to do with our strategy to ensure continuity of this very important landable project. The administration and licensing of this are very important. Institution is continuous, and then there is a deliberate effort by government to ensure proper coordination, supervision, oversight of this PTND. And then the plan for the PTND also be appreciated in processes such as awards, conference, or seminars, was also encouraging for the PTND to also work. And most importantly, also the leadership and coordination, especially in the private sector and the public. Those were responsibilities that have really helped. And then even in the context of tax and tax sharing, you find out that a lot of people that have supported the program were happy to see that they have put their hands as part of the corporate social responsibility to support government in discussing the basic services for food towards agencies.
Dr. Ibrahim, please forgive me. The sound is of poor quality. I wonder if Tito, you might be able to step in and provide some clarification. The comments online say that it's been really hard to understand Dr. Ibrahim. So I'll repeat the questions perhaps for you. Just asking about transportation costs. And maybe I'll add another question there. Some follow-up about, let's see, how can this engagement be sustained? This work that you developed already under Breakthrough Action, how can we scale it up and how will it be sustained? So Dr. Tito, if you wouldn't mind answering that one.
Thank you very much, Claudia. And apologies for not joining earlier. So the clients are usually transferred or referred to the health facility closest to them. And they were not asking for transport fare because at that point in time, they are also anxious to get a correct diagnosis, especially if they have been treating the illness for long time, coming to buy the cough syrup or the antibiotics across the counter. And then the referral slip contains the call center number 3340. So even if they don't want to go to where it is close to them because of confidentiality or fear of what the diagnosis might be, when they call the 3340, they can go to another place that is maybe not close to them in where they live or close to where they work or something. So we have not had the issue about asking for referral. And in terms of sustainability, because the referral concept was very easy, you just tear a paper and give. And then we have LG supervisors that were always going to meet them to see how they were faring. And then some of the benefits that they got, like if somebody they referred is positive, one of the PPMV said, every time the person passed, the person will greet him, well done, sir. Thank you for the other day, So that feeling of being appreciated also make these people to continue to support the process without expecting any monetary return. Apart from that, we also try to talk to their association. So with the hope that they will recognize all the people that have been working with us, appreciate them for the lives they have saved, for all the referrals they have made, people that were diagnosed early and put on treatment, and then encourage other people to join. So we have PPMVs that have recruited other PPMVs just because of that. So that's the sustainability plan, working with the association and encouraging them to recognize all those people that are doing such voluntary services for the health of their people. Thank you.
Thanks, Tito. I'm going to pass now over to another question that I think was very interesting and invite Tissera to answer out loud. This is a question on anxiety and depression are typically foreign topics within some African communities. How did you handle that in Ethiopia? So Tissera, if you could come off mute and talk a little bit about how how you were able to broach the topic of anxiety and depression. Is Tissera still online? I don't see him. It looks like we may have lost Dr. Tissera, so maybe we'll move to another question. Maybe Leah, you could answer. There's another one here about, could you please explain what appears as a discrepancy in terms of an intervention effect on the percentage of using contraception versus those who have an intention to use contraception? And that was from the results that you presented.
Yes, I'm happy to take that one. So as I mentioned in the presentation, so we measured uptake in contraception, then we also looked at intentions to use family planning. And we were grappling with this question too. But when we looked at the data, so intentions to use was already really high at baseline. So around 80% of participants had an intention to use family planning. So the reason we had ended up presenting that graph a little bit differently was we wanted to see among those who had intentions, did that translate into changes in family planning uptake? And when we looked at that, it looked like those among the intervention group who had intentions that actually translated into use. We're still exploring how to test that significantly, but when we look at it descriptively, that's what we were seeing. And I think another piece in terms of the lack of intervention effect, given that rates were already high at baseline, there's not a lot of room to move. So we've been exploring that one a little bit more qualitatively and characteristically.
Great, thanks for that. And I see that Tessera is back online. Tessera, there's an interesting question here for you. Just wondering about how in Ethiopia you were able to handle the kind of challenging questions around mental health. I know that's your area of expertise, so I'd love to hear how anxiety and depression are topics that you are able to study and to share in your work.
Okay, thank you so much. Both common mental disorders, anxiety, they are under common mental disorders, and anxiety and depression are very widely prevalent in the area, particularly in Ethiopia. About 33% of perinatal women experience the anxiety symptom, depressive symptoms in particular, and anxiety is also very common too. Particularly, the severity of these symptoms also varies. For example, the mild level is very prevalent, and the severe level is somehow less prevalent. And those severe levels are currently managed in hospital level, in the tertiary healthcare level. And the healthcare service in Ethiopia is very centralized in urban areas alone, in regional areas alone. And those mild levels are not totally considered, though they are very, very disabling conditions or symptoms. Those mild levels are responsive to psychological treatments and interventions, but they are not considered and they are not treated in current healthcare system. And that is why this is a motive for us to come to the CBT, which is psychological intervention, and that is supposed to be, that's proven to be suitable and being used in high-income countries too, and not much in low-income countries, however. So we adopted this intervention that has proven the evidence following rigorous steps in Ethiopia. And then we adapted it. We changed it into the language that is suitable to Ethiopian women. And we tested its feasibility, and we are now reporting the efficacy of this intervention in this randomized control trial, which is actually promising as we have seen the results. Thank you.
Yeah, it's very exciting. I think it's such a breakthrough in terms of being able to address anxiety and depression and stress among new moms. I think it is very exciting.
It is exciting again. And what remains, a question I have seen by one of the participants is, these concepts, anxiety and depression, are more of, the foreign concepts, and how they can be applicable to low-income countries, to particularly Ethiopia, was a question that was very important, I feel. And, the symptoms are there all over the country, all over the globe, but the severity and the conceptualization of these symptoms of depression as well as anxiety actually vary from one country to the other, from one culture to the other. And in Ethiopia, we use a locally validated version of screening tool to screen these symptoms. And then we also adapted the intervention according to the culture. And actually, these symptoms, as we have screened using local screening tools, they are disabling conditions.
Yeah, I think you probably could speak at great length about mental health issues, and I really appreciate that. However, we're going to take one last question for Colin. Colin, s'il te plaît, j'espère que tu es toujours là. On demande s'il y avait quelque chose que vous avez donné par rapport au ticket de rappel, s'il y avait quelque chose, une valeur par rapport au ticket de rappel. Donc, si tu peux répondre à cette question. Et puis, il y a une question dans le Q&A qui demande ton contact. Si tu peux répondre à ça directement. Merci.
Ok, merci. Une valeur qu'on avait donnée au ticket de rappel, ce que je peux dire, c'est que si nous avons mis le ticket de rappel, c'était pour mesurer l'intervention. C'est vrai qu'on a mis l'intervention, c'était vraiment apprécié dans la communauté. Et quand on passait l'intervention, la plupart des participants hochaient la tête parce qu'ils étaient vraiment très contents. Et on dirait que c'est pendant l'intervention qu'ils se rendaient compte que les coûts réellement des soins ne coûtaient pas aussi cher. Bon, bien sûr, les soins de santé ne coûtait pas aussi cher qu'il les pensait. Alors, mais tout cela, il fallait qu'on se rassure, par exemple, toutes ces activités que nous faisions dans la communauté, est-ce que réellement, parce qu'au finish, c'était améliorer l'utilisation des services de santé, est-ce qu'au finish, les gens se rendaient dans les services de santé, dans les centres de santé, pour prendre les soins en cas, par exemple, de fièvre ou en cas d'un problème de santé, d'accouchement, ainsi de suite. C'est ainsi que nous avons mis les tickets de rappel. Ce n'était pas pour casser les systèmes, parce que dans notre système, bien sûr, il y a les jetons de référence. Ça, c'est au niveau des centres de santé. Si, par exemple, on doit quitter des centres de santé au niveau de l'hôpital, là où il y a un plateau technique un peu plus élevé, il y a les jetons de référence. Mais au niveau de la communauté, comme il n'y a pas vraiment dans notre communauté un document quelconque, nous avons mis ces tickets de rappel pour arriver à mesurer un peu l'impact de ou de nos activités communautaires au niveau de l'utilisation des soins. Et là, nous avons fait globalement, mais aussi à l'intérieur, nous avons essayé de voir la valeur que chaque activité communautaire, par exemple, que ce soit l'effet des couples, que ce soit, par exemple, le coût comparatif, a mené au niveau, par exemple, de l'utilisation des services de santé. Donc, une valeur comme telle financière, oui, dans la production, ça nous a coûté un tout petit peu, bien sûr, mais la plus grande valeur que nous avions, parce que nous voulions mesurer réellement l'impact de nos activités sur l'utilisation des soins de santé. Voilà. Et par rapport au contact, je crois que je vais partager dans les chats
Oui, s'il te plaît.
l'email, je crois que ça peut aller. Merci.
C'est très bien, merci beaucoup. D'ailleurs, if there are any other responses that our presenters would like to respond in the Q&A, I'm sure people would be very appreciative of it. There is a question that was responded to in the chat as well. So please check the chat as well as the Q&A. I did want to make sort of one final remark that I think what is really exciting about these three innovations that were shared today, they really create this bridge between SBC, social and behavior change, and the health system. We've seen in all three examples, whether it's tuberculosis or maternal health, or this more general overcoming an obstacle of perceived costs for health services. In each of these three examples, we've seen ways that SBC has been used to overcome so many challenges to using the health system and to being able to, excuse me, thrive in our various environments. And so I am really excited that we've been able to share these three innovations. And so I will ask, I think it's Marcella to put up the slide 48. Thank you. So as we conclude today's session, I'd like to thank our presenters once again for their valuable insights and for the work that they're doing to advance health outcomes through SBC. I also want to thank all of you for participating, for your thoughtful questions and comments. One thing before you leave the webinar, please complete the 4-question poll. You will see that shortly. This will help inform future webinars in this series. Also, if you're interested in learning more about these innovations that were shared today, please take a look at these great resources. And so the bit.ly, I think, is going to be shared in the chat. So you've got the poll there, you've got the bit.ly as well that's been shared by Lisa in the chat. You'll see that Adobe Express page has more information about the 3 innovations shared today, in addition to a handful of other innovations. And we're very excited, Breakthrough Action, we're going to be sharing our Breakthroughs Gallery. That's going to be a new feature on our website. We encourage you to go and explore, what do we mean by a breakthrough, and how is it that we're embracing these innovations. Yes, we will be receiving, I believe all of the presentations will be made available. Thanks, Lisa, for putting that in the chat. And hopefully people have participated in the post-webinar poll. And so remember, this is just the beginning of our journey in this series. Breakthrough Action invites you to the next webinar in the series, which we call Advancing the Field of SBC. That's on October 29th. And until then, we ask that you take care. We look forward to seeing you again in a month.